We have the other members on.
Ann is here.
Ann's there.
Ann is here, as is Steve Burrow.
Mr. Burrow, oh, he's joining me. Right.
Yep, we is in.
Then. So no
All
Ellie.
those online, can you hear us clearly? Ann, can you hear us?
I'm here.
Okay.
You can hear us. Awesome, thank you.
All right. Is it 9 o'clock? Oh, it's 9:01. Oof.
We are recording, everything's up and ready to go.
What's wrong with me? There's nothing wrong. All right.
West Coast time.
Yeah. All right, I'm gonna call this meeting to order. We've got the agenda in front of us and we'll get started with the approval of 2 sets of meeting minutes. One from the regular meeting, February 9th, and the second being from February 23rd, the special meeting minutes. Any, issues?
I move we accept the minutes
Both February and special?
and 23rd, the 9th and the 23rd.
I second.
All right, all those in favor say aye.
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 Okay, I mean, I didn't see anybody for public comments online. So we're gonna proceed. Oh, Elliot needs to be admitted. All right. Hey Elliot, can you hear us? Elliot, can you hear us?
Yep, you should be able to hear you.
He's not responding
right now.
He's muted. Can he unmute himself?
He should be able to. I asked him to. Well, he might still be like connecting to the audio.
There he is. Elliot, can you hear us?
Right out of it. He's still on.
Elliot, can you hear us? No, Ann can, so we're good there. Steve, how about Steve Burrow? Steve, can you hear us?
Yes, I can hear you. Good morning.
Even 4 years in, we still have technical difficulties with Zoom and stuff.
Right.
Nothing perfect.
Oh,
It happens weekly.
humans.
Yeah.
I texted Elliot.
He might just be having a microphone problem on his side.
He can't hear us.
Oh,
No,
that's
he said he
strange.
can't.
That's not on our end then.
Yeah.
I think that was, I think.
I agree.
Yeah, this is Anne. I hear you fine.
Thank you, Ann.
Thank you, Ann.
My presentation at the county commission.
Well, I wouldn't see that too.
Okay. So, boss.
Yeah, can we talk about it? Is it on the agenda?
It is not, but I'll be more than happy to speak with you afterwards.
Yeah, I'd love to get an update.
Sure.
Well, you can also cover it in your update.
I can cover it in my, actually, I do have it on as a bullet point. I don't have my report, so.
All right, so barring no public comment. We're gonna go into unfinished business with the adoption of the new rule regarding the environmental health fees for permits and services. Have we received any public comment on that?
No, we have not.
We have not. Okay. All right, well, we already hashed this out in a special meeting, there a few weeks ago. Brandon, do you have any questions?
I do not.
Okay. All right, is there a motion?
I move we adopt the environmental health fees for permits and services as they exist now.
I
That-
second.
Thank you, Anne. Any discussion? All right, all those in favor say aye.
I
Aye.
Aye.
Hi.
All right, motion passes.
Oh, now we can hear it?
Yeah.
And we can hear Elliot.
Morning, Elliot.
Good morning. How are you all?
Good.
Good.
All right, we'll move over to Charlie, call sign Charlie.
All right.
Sorry, Top Gun's my favorite.
Good choice.
I've been holding on to this for 3 years.
Good morning, everyone. Thank you for having me. I would like to know, I also have the November 2023 revised financial packet. The only change was there was a footing issue that I'm not really sure how it happened because it's all in Excel and I print it to PDF. But that footing issue has been fixed and now the summary sheet matches all the support behind the summary sheet from QuickBooks.
So it was confirmed that it was just the summary sheet that was.
Yeah, it was just a summary sheet on all of them, because we pulled the information from QuickBooks into that summary sheet, so you have something that is a useful management tool. So I apologize for that. December, the only thing that was wrong was that it didn't flow from November into December. I did note when I reran the reports, there were some more deposits posted, so that increased the bank balance by about $30,000. And that also reduced the accounts receivable, but no major changes to December, but it now all flows properly.
So I think we didn't accept, I think the vote was that we did not accept them.
Did
the
not
last
accept
time,
them.
So,
Okay. I thought,
Yeah.
Accept them.
no, I don't think we did. It was a 3-2 vote.
No,
I thought we accepted them as
Yeah,
well.
the two against.
Yeah,
Okay,
yeah.
I think the way the motion was
You were
was
against.
submitted,
Yeah,
Right.
I think the way the motion was submitted was, let's go ahead and approve them all, and then
Right.
it passed 3-2.
did it? Okay.
Yes.
I'm
All right.
almost certain.
Okay, then no action
You
needed.
want,
But that
you
was
want
for-
to accept the revision.
Yeah, maybe.
you can accept the.
Let's deal with those two right now.
That's fine.
So they were separate. Is there a motion to
But I
accept
think
the
we only
revised?
approved 1 month, didn't we?
No.
No.
it was 2 months.
It would've been
Was
two-
it November
yeah,
and
March.
December?
Because last month I would have presented November and December and the preliminary January.
Right. So is there a motion to accept the revised summary sheets for November and December?
I move we accept the revised summary sheets for November and December.
Second,
Any discussion? All those in favor say aye. Aye.
Aye.
Okay, the motion passes.
All right.
I don't think there was I don't know, Ellie, if you meant to not vote or if you'd like to be marked as abstain.
still not having issues with this.
I voted aye.
Okay, sorry, we didn't hear you. Thank you.
I raised my hand.
Oh.
We can hear that.
All right. So now we'll go into
January
January.
2024 financials. 58% through the fiscal year. Bank balance of $408,000. And we are not in compliance with the reserve requirements by approximately $53,000. One thing that I would like to note, and especially December too, but January and February, is that your operating expenses are a little higher than usual. There are some renovations and some equipment purchases that are driving up your previous 3 months operating expenses.
Okay.
We're looking at about $35,000 there. Then to go to the financial summary, January. Revenue, $24,000. And we're gonna reduce that by salaries and wages, about $95,000, and then operating expenses, $19,000. Leaving us a deficit for the month of January alone of $90,000. Now, if we look at fiscal year to date. Revenue, $764,000. Salaries and wages, $694,000, and we're gonna reduced by operating expenses of $274,000, leaving us a deficit for the month of, or through January 2024 of $204,000. And if we compare that to last year, as of January, we're doing a little worse than we did last year. We're at a loss of 204. Last year, we were at $158,000. We're gonna see that turn around a little bit in February. As far as how we are performing against our budget revenue, we're 7% below what we budgeted. Salaries and wages were above what we budgeted by 4%. And then, remember I told you we had those extra operating expenses? Operating expenses are 36% above what we've budgeted. A lot of that was also due to vaccines. And I think you can see the benefit of buying the vaccines when you look at the revenue on the clinical side. We're at, I believe it's 95% or 90% through January, 90% of what we budgeted. Yes, we have extra vaccine purchases, but we're also using them in generating revenue. Accounts receivable, $356,000. $248,000 of that is related to West Virginia, state of West Virginia. That is 70% of the accounts receivable balance. Nothing else was above 10% of the total balance.
Any questions for Charlie in January?
Yeah, hold on. Can't seem to.
Huh.
Can
We're
you hear
still
me?
here.
Yes.
we can hear you.
Oh, great. My only question is, what are the consequences of, I understand for a month or two, if we are not in compliance with our reserve requirements, how long do we go before we need to start really focusing in on that?
Usually a quarter is a requirement, so, if you'll look at February and you'll see that revenue is increased well beyond expenses, and that number is not completely turned around, but will be completely erased probably by the end of March.
Oh,
So,
great.
Because of the one, part of it's because of the one-time expenses, I guess.
Mhm.
and I'd like to explain what those expenses were. First of all, we renovated the 2 clinic rooms that hadn't been renovated since the 1980s. They were quite dated. So we spent about $15,000 on that, and then we also had to buy some equipment related to the exam tables. So we purchased a new exam table. It's quite excellent, but it's not inexpensive. So those types of costs. I'm sure Brandon's quite familiar with medical equipment is certainly not cheap.
So was that not budgeted in though?
It wasn't originally budgeted in, no,
So why not?
because it was an unanticipated expenses, unfortunately. So Dr. Reedy and I discussed it, and it seemed like a reasonable expense at a time when we could afford it. So.
If you haven't seen them, you should go.
No, I have. I'm not disputing the upgrade. It's just sort of, that's the kind of stuff that should be sort of, I think, thought through at the start of the budgeting season versus
I understand.
then we're in this situation. So.
One of the things about this office is the way that expenses and revenues ebb and flow, and that's sometimes very difficult to anticipate when you might have enough in the bank to be able to afford things like that. And when
Right.
you do have it, you try to strike while the iron's hot, and that was an opportunity. I felt that we could expense something that needed to be done.
And we finally had a full staff to use those.
True.
What do you do with the old equipment?
It was completely destroyed and dated, well over more than 40 years old.
I just didn't know if that's something that you were able to donate to.
Yes, it was sent to recycling because it was almost all steel.
Oh, okay.
So remember in the 80s when you go into these places and they'd have all the steel cabinets and all that, that's what that was replaced. It's much nicer, it's wood, it's much warmer and more pleasant to work around, and certainly looks better when the clients and the patients come in and see it.
Thank you.
Yeah, it sounds like a nice upgrade and necessary, given the dated, setup that you had. But I will say, I agree with Karen on budgeting awareness, that's a pretty big expense.
It is.
I think it's better that's a better practice, I guess, maybe what we're trying to say.
Still learning.
Sure. I'd like to see it. Maybe we can do a quick tour after the
I
meeting.
think we can.
Excellent. Look forward to it.
Any additional questions on January?
Did you want to approve it?
I didn't know if people wanted to maybe go through February, because there's a bit of a turnaround that's happening in February, so maybe let's go through February before we accept January.
Sounds
Just
good
so
to me.
people have a,
Full picture.
because I'm not super happy with January, but I know February looks a little bit better, so.
All right, February 2024. We're about 67% through the fiscal year. Bank balance, $378,000. I do want to say, I think that's a little high, about $10,000 to $15,000 high. So just putting that out there. So bank balance right now sits at $378,000 on your balance sheet. We are still not in compliance with reserve requirements, about $66,000.
Okay, so that's going, sorry.
So it
it's going
did
up,
creep up a little bit.
Right, but
yes.
so how much of that is, are the one-time costs?
That was a
30.
December expense.
Yeah.
So that raised the average about 30K,
Yes,
the three
In
month
terms of,
average.
so 30K, so we're
Still under,
technically
still
about 36,000 that
above the reserve.
yeah.
Or below the
below.
reserve, yes.
Yes, I did calculate it. We still weren't meeting the reserve requirements, but definitely much closer than that 66,000.
And generally, our operating expenses have been declining over the last 2 months, so that will change the reserve amount too.
Once the December goes out of the average.
Once the December goes out of the average, but also you look at February's operating expenses and salaries and wages are a good bit lower than they've been over the last.
So
previous
December
3
will
months.
come out the average in April.
Yep. Sorry, Charlie.
No, that's fine.
But this is 4 months of a negative reserve
Yeah.
requirement.
Yes,
You know, and I think if quarter is the standard, we're at 4 months.
Yep.
You know, I'm just, as the new one on the board,
nope, you're right.
yeah, like, at what point, and to Elliot's point, precisely, like, at what point do we raise the alarm and lean in on that?
Mhm.
You know?
Now. Like you're doing.
Well, I think
Yeah.
we need to start to see some management of operating costs.
Yep. And you'll see that in
the
February,
next
in
month.
February, you'll see
Yeah.
that. So continue, sorry.
Okay. February, for the month of February, revenue, 216, almost $217,000. That's almost 100 grand of NEHA and 56,000 of threat prep billings that went out in February.
What was the 56?
Huh?
What was the 56,000?
The-
What was?
the-
Oh.
The threat preparedness grant.
Yeah, sorry,
Okay.
56,000, yeah.
And
So
what was
that-
that first word you said?
NEHA,
National Environmental Health Association, it's for the environmental health grant. Okay.
That's what supports one of our sanitarians
Gotcha.
positions.
Yes, sir, gotcha.
So then we're gonna reduce the revenue by salaries and wages of 87,000, almost $88,000. Then operating expenses of $11,000. There's a surplus for the month of February of $118,000. Fiscal year to date, revenue, $980,000. We're gonna reduce that by salaries and wages of $781,000. And reduce that again by operating expenses of $285,000, leaving us a deficit through January of 2024 of $86,000. Now, if I compare that to prior year, we're at a deficit of $86,000. Last year, we were at a deficit of $130,000. And permits started hitting March last year, right?
April. So,
Yeah.
yeah, they billed a little earlier last year because, we were switching to that online credit
Yes.
system, so she wanted to get the invoices out earlier, but this year she's not starting until April and it might take a little longer to do it this year just because we're down one staff member up there and then we'll be training somebody here next week.
So as we're thinking about how things works cyclically around here, we have that seasonality. Let's keep that in mind as well.
Sorry,
Yeah,
So it's gonna take longer, but how long? Because we're coming up on the end of the fiscal year.
Right,
so-
we,
and
well,
we're
all the
budgeting for
buildings
next
will
year.
be done before then because the permits expire June 30th.
Okay, but we were also gonna be voting on budgets
Right.
between now and then as well, so. We wanna work with as part of a number as possible as we're making those
Absolutely.
decisions. Because we have to do our budget, then have to submit it to the state, which I think we have to probably approve the budget in May,
May,
so.
that's what we did last year. I'd like to do it again in May.
Yeah,
I
well,
prefer
'cause-
not to wait until June. I
Correct.
would prefer to have some hard numbers. So once the state comes through with hard numbers, hopefully at the end of the legislative session, I'll be able to produce a little firmer budget in April and then a firm budget in May.
I'm talking about like also the invoicing and all of that kind of stuff, if there's a prioritization, that's probably it, because we have to make decisions based on.
It's typical for it to start in April, so.
Yeah, previous years, it started in
Mhm.
April, March. Last year was the
It
first
just
time.
spoiled us, so we like it,
Yeah, I liked it too.
Yes.
so,
Last year was early, and then the year before that, it was a little late.
right,
That we started to see that uptick later in the fiscal year than anticipated. So, even if we're at April, I think we're, on trend.
And,
Yeah.
and our person that does the invoicing doesn't even have the capacity to do that right now, so.
what are they
She's
doing?
been swamped with all the well and septic applications and every other thing that's coming in. She's doing scheduling that she wasn't doing before. She's taking the other position as well as hers right now, so. That's been vacant for over a month now, so.
We'll talk about that later.
And just two more things to touch on for the February financials. Let's compare it to what we budgeted real quick. Revenue of $980,000, we're meeting expectations. We're right on our budget line item for revenue. And I would also like to point out clinicals at 96%, 97% of what we budgeted for clinical.
So we have a chance to exceed that then.
Absolutely. Salaries and wages, 3% above what was budgeted, and then operating expenses, 32% above what was budgeted. Again, noting the renovations and other purchase, the table.
And vaccine
purchases.
purchases.
And vaccine purchases, correct. Accounts receivable went up, $442,000, $327,000 that is related to West Virginia Treasury, State of West Virginia. Any additional questions on the February 2024 financials? Oh, I did want to point out that, on your February, there are certain numbers in your summary that tie out to the underlying support. I made sure those numbers were highlighted for you, so you could see where we pull those numbers from.
That's a helpful update. Thank you, Charlie.
That was one of Dr. Reed's suggestions.
Thank you, Dr. Reese.
Yeah, because I find myself looking through, say, where did that number come from? It's like, oh, we don't show it here. We calculate.
Yeah, some of that we do get from the system and put that in the summary for you, because if we added all those work papers, the packet would not be beneficial, right? Because they're just too much. So the numbers that we do pull from these sheets are highlighted.
Any other questions for Charlie? There a motion to accept the January financials?
And then we accept the January financials.
A second.
Any discussion? All those in favor say aye. Aye,
Aye.
Aye.
thank you.
Your
That
concern is
passes.
noted. As you can see in February, operating expenses were much lower than the previous 3 months. That will probably continue for the next couple months. We're well stocked on several things and there will be I don't foresee any unexpected expenses. So we should
You
be right.
anticipate March being over the reserve requirement?
Yeah, probably, or right at it, for several reasons. First of all, the reserve requirement number will go down.
Yeah.
I
That's
think
gonna
if
be
the
good.
average will go down, that'll have a big effect. And then we're continuing to generate a good amount of revenue on the clinical side. And we will see a little bit of an uptick on the environmental side heading from March into April.
And I don't think this is really important to note, is that there are some of the bigger expenses that are grant funded and that grant hasn't been built out yet.
Yes, I just was able
Yeah.
to bill out the threat preparedness grant because we didn't receive it until February, authorization to bill it. So I billed it in February, so that we had accumulated expenses from Q1 and Q2 related to that of almost $60,000, more than $60,000 actually. And I was able to bill that out a couple weeks back, and so that's hit the bottom line. But there's also second quarter for the QRT, which I know you all wanted to have a report on, and I can give you a quick one on that. So we have any expenses that are related to that. I can do that in my, I can do it in my, let's do it in my administrator, sorry. Let's keep going with.
All right,
the
I
agenda.
know you're on a roll.
Yeah, no, you're right.
All
Thank you,
right,
everyone.
thank you, Charlotte.
Thanks, Charlie.
All right, appeal process for on-site sewage disposal permits. I think it's Dr. Reedy.
So just before I became health officer, this is 5 years ago, as Ann Smith remembers well, there was we had transition in the environmental side, entirely new people. There was a lot of concern that the way that permits were being done primarily in the septic and well fields, that there was something wrong, and there were calls for looking at our policies. And so one of the policies that was policies the correct name, but that's what it's hard to know when it's protocol and policy and regulation, but this was one that the board looked at and was accepted by the board in May of 2019. That when permit for a septic system was denied, that the appeal process would be the health officer. And then if it was still denied, then the person could appeal to the Board of Health, or they could just go straight to the Board of Health and bypass. We have had shortly after that, there was so 2 months after, there was one denial that was appealed to the board, and that was upheld by the board. Since then, there have been 2 appeals that have gone to the health officer, and they have been upheld through the process. The one concern looking at the state regulations, both the and several
Sewer system, sewage treatment and systems, septic tank cleaners, and then the sewage treatment and collection system design standards, and several of our other state rules.
and then there is one so actually the first #1 code of state regulations for I guess the health departments is contested hearings. And so that's what this would fall under. And that gives the director or the commissioner of health or his designee, which becomes the local health officer. And Steve Grove, will interrupt when I say something that's not legally correct. The ability to do the hearing or appoint a hearing officer. And then if it is upheld, then it says the person has the right to appeal to the judicial system. So I don't see in the law that appealing to the board is actually part of that. So I'm raising that as just a concern that we want to be following, whatever the law is. And And then the one other piece is in our policy, after the hearing is done, the health officer, the hearing officer has 10 days to submit the finding, whereas the law gives 30 days. And that just is a problem if you end up having a hearing on a Friday and then you've got 2 weekends for that. So it doesn't say 10 business days or two. So you just bring that up as an aside. I don't know if Mr. Grohl wants to have any comments.
Good morning, everybody. I looked at the local rules and then there's the state regulations that apply to all the agencies. It seems like there's a couple questions I have for Gillian and them. Is this the only thing that we actually appeal is the sewage disposal permits? I mean, if we're gonna make a rule, do we want to make a rule that covers other stuff, or is there really nothing else that people have? I mean,
So we've only had, since I've been here, appeals for septic permits, but people have the right to appeal basically in all of our rules, and they all refer to the same state rule, which is 64 CSR 1 for the contested case hearings and declaratory rulings procedure for appeals. So I think what we're saying is we should just do what the state regulations say and use 64 CSR 1 and not this local policy that was adopted 5 years ago.
yeah, there's a lot of moving parts in the state regulation because it covers a lot of, I mean, it's more generic for appeals. Frankly, I don't see anything in the rules that say we can have a local hearing anyway. But I mean, I don't know where the original rules kind of came from. But on the other hand, there's been a lot of changes lately since the COVID, letting boards of health have extra authority. So I'm wondering if we do the process that lets the commission adopt rules, if we couldn't do it that way and have it locally, because it seems like it'd be easier for people to do it locally. And it would certainly be a little less bureaucratic, but it's
So
The process is generally the same for people. The rule talks about the commissioner or his designee, and that's always been the local health officer. So in these cases, when people want to appeal, they're still appealing to the local health officer, which is Dr. Reedy.
But you're saying
And-
the next process of coming to the board would be what would be eliminated? They could go directly to,
Right, because it doesn't provide for that.
Okay.
here. So.
it would, yes, so there's the state code on the regulation on contested hearings. And then it says agencies will have their own rules, and so the Department of Health has its rules. Its rules are under Title 64. And their number 1, Series 1, is Rules of Procedure for Contested Case Hearings and Declaratory Findings. So that's the one that I look at. And it says, and it defines, so hearing on written request, when the commissioner is presented with the hearing as described, he or she should conduct a hearing within 45 days. But under commissioner, it's defined as the commissioner of the Bureau of Public Health or his or her designee. And that typically for a lot of the things is for public health, it'll say the commissioner does this, but then it's designated to the local health department. So that's where we come in.
having been there when this was adopted and this was discussed over and over and over and over. I am thinking that that might be what the state code said at the time. Is it possible that that has changed since then?
Yeah, the Department of Health and Human Resources no longer exists. I mean, all these laws are going to change a little bit, and whether little bits of the definition change, I don't know. I mean, we could. I guess we could ask the. Someone at the state level and they can have their attorney give an opinion on.
This is Anne. Can I have some share some of my thoughts on that?
Please.
Dr. Reedy, there's no offense at all to you. However, I think that the authority to do a repeal is better to have a balance of power. So a panel of board or a panel of the commissioner, of 5 people to do appeal is much more balanced than authority of one person. That's just my opinion. Whether they repeal to the commissioners or a board, the Board of Health, I think is so much more balanced than just your opinion. Thank you.
So I think I think what we're getting down to the crux here is that we're compliant with state code, right? We're consistent with state code. Personally, I think we need to know almost not in verbal, but side by side. This is what we're doing. I know we have the appeal process that you supplied with us and we gave a state code, but what's the side by side?
I think one thing to consider is if we are not compliant with state code, especially for something as important as a contested hearing or an appeal, that would open it up for somebody to sue us. And
100%, but right now, I'm not comfortable making a decision because I don't know what the side by side is here. Because we've been doing it this way. So
Well,
tell us what it is.
It really hasn't happened but one time, and that was
Yeah,
years ago when this was really sort of adopted.
Mhm.
Since I've been on the board, there was one appeal.
right, but what I'm trying to say is not about our opinion, it's not about how we feel or if there has been or hasn't been an appeal. It's what does state code say and what do we need to be compliant with state code, and we follow state code.
I agree.
Right, that's exactly right. What are the differences between what the local procedure or reg is and what the state is? And if they need to be reconciled, either go to the state and ask them or just to comply with the state. Exactly right, Karen.
Isn't there something in that code that also asks for the state health officer or the state? So didn't we do that before with bringing somebody in from Charleston when we had these issues?
so I don't think that was for this. I think it was for the other permitting of the lots. I don't think it was specifically for this process when we brought somebody in. That we had 2 attorneys basically that we were talking to at that time. But I don't recall it being for this procedure. Well, it's called an appeal process for on-site sewage disposal permits. It's just a process that was adopted by the board several years ago.
But they had to get the septic permit in order to get through.
Yeah,
lot of
they
approval
had to have a denial.
Right,
And then,
right.
then they can appeal that, so.
Right, and I think this is when we brought in the state officer also to do
It's
a
that,
review.
So we have had a separate sanitarian type review of someone
Right.
who's
Right.
more a technical expert.
Right.
The hearing officer is being presented the evidence, but not actually going and measuring things or something like
they
that.
had 2 attorneys, but I don't recall anybody from.
Well,
the
I think it would be Rick
state.
Hirsch's that we're talking about.
Oh, state,
Yeah.
well, yeah, that would, he's just to provide a second opinion on the lot.
Well,
so-
I mean, my recollection of this process was that obviously our staff did a review, and
Right.
if they denied a permit, then you called the state officer in to give his second opinion of that with whether or not you were right. And
We
that,
still provide everybody a chance to get a second opinion.
from the
However, Rick Hirsch's is not always readily available, so if they want a second opinion outside of our office, we've started asking Marty Snyder, who is the district sanitarian, he's state also, so
And-
he did come in
Right,
and provide his opinion. So he did that for the last appeal that we had because we were
And
not.
then the
able-
next step was they would go to Dr. Reedy. You know,
Well, yes.
if the answer was still the same, that the permit was denied, and then only once did they come to the board. And the
Right.
board actually made a visit. Were you here then up to the lot?
Yes.
Yeah, all of us,
Yes,
Yeah.
yes, we drove to the mountain to look at the lot.
yes.
Yeah.
Mhm.
So, right.
I think there might be a way to reconcile a local process with the rules, the state rules. I mean, but it looks like, I mean, with other issues we've had before, like, because the health department are state employees, we'd go to the regular administrative law judge, we'd have to drive out of town, we'd have to conduct these kinds of, follow the regulations. And the downside with that is, it puts a lot of expense on whoever the local person who wants to get their thing done. So we might be able to reconcile this, but we ought to probably talk to the state and say, hey, we're not gonna have the appeal process. You still have your regulatory framework there, but we could look at this as an informal way to get a review for people that's quick and easy locally. So if there's a local mistake, we can fix it quickly. And if they don't like it, they can appeal through the regulations that exist. So give them an alternative, and they can always just go, I think they can always just go directly to the commissioner if they want to, because, it exists, but then that's a burden for them. They don't want to do it. I mean, I don't know how successful these things are. We just had a hearing the other week, and it seems like this sort of a scientific determination is what it is. But on the other hand, that's a lot quick and easier for people if somehow we made a mistake and they can convince us without having to hire lawyers and go other places. But it is there's so many moving parts on this. It's really unclear because they want to give so much local authority to the local boards after the COVID thing that there could very well be some leeway. Just my rough take on it is just so people have a way to get to a court at some point, which they do, then they've got due process going. And having the two steps to it, I guess we could make our own rules up, but it does seem sort of redundant. But I'm gonna have to. Why don't we I'll have to talk to Gillian, because we can't take an action on something vague anyway. We'd have to have a written specific proposal to go through. So why don't I work with Gillian and Dr. Reedy and Nathan, and we talk to people down in Charleston and see where we are. If we can have a parallel process, or we just want to default to the state process and come back with something a little more concrete as far as a recommendation.
I will tell you that the state, anytime the Office of Environmental Health Services, who is responsible for the regulations that we enforce, always tell us to refer to this for appeals and hearings, 64 CSR 1. So I don't think they're wanting us to have our own local rules for this.
Agreed. And so, to Steve's point, let's go get the determination from them. Let's have a side by side of what it is that you're asking us to take action on. So long as it's compliant with state code. And if there's something like in state code that like, hey, we should have more local control over this, then hey, we can change the law. That's a good job for a lobbyist. So like, if there is a concrete example for us to maybe pursue a change in the law, which obviously wouldn't happen until next year, then we can evaluate that. But at the same token, right now, this is state code and we need to follow state code. But we also need to know what it is that state code says versus what we're doing and get it reconciled.
Yeah, and then trying to balance the ability to get a local quick determination against the avenue, and it's almost like without seeing the code, is there just a step 9, if this all fails,
It's
then you have
not in what we were supplied. That's what I've been looking at. And the thing is, the other opportunity too, is you've got the state office on the environmental side, but you can always get an opinion from the AG's office too, if we need to, so that also, and if AG says, oh yes, you can do this, then we have that to stand on, which satisfies the liability piece of it, the lawsuit liability. Cause right now it's 5 years and we're, I guess, not in compliance with state laws, so. You know, so you can get,
I think ultimately, as far as the due process goes, we have a lot of local things that we have consideration. And then there's a mechanism in state code to get into circuit court to review any government action. So I think people, even under these rules, we don't have to specify the local rules that we're talking about. We don't have to specify they have a right to appeal to circuit court because that's in the state code. So they can always go to circuit court. I think people have an avenue to get judicial review, which is the kind of key to it. But on the other hand, I think, and you know, this would kind of predates me, and I'm looking at this that I don't. We might be able to reconcile the two, because the downside is, does anybody want to have to go to Charleston if they can get it resolved here?
right,
But if they don't like our result, then they have these other options. So it kind of strings it out. But on the other hand, it's not irrational to give people a cheap and quick venue to get a review of what's going on before they have to go to court. So maybe we can reconcile these two, and they're not like diametrically opposed, you know, because it's so much easier. Like the one we had the other week, that local businessman came out, we had the hearing, he didn't have to drive to Charleston, he didn't have to do anything. Now, he might not like the result, but on the other hand, he still has other options that he's got, and we'll have to talk it over and see, because it doesn't seem to me it's harmful to have
Steve, I think
some
some
sort
of
of
the-
informal option.
I think some of the confusion that, they, even with the state rule, their first step is going to be a hearing with the local health officer. So it's going to be the exact same as what we did last week.
Uh-huh.
And then just following the state rules and procedures after that.
mhm,
So
Yeah,
so
that's what-
basically, the main difference is our rule is giving them the option to appeal to the Board of Health afterwards, or to skip the hearing with the health officer and appeal directly to the Board of Health. And that right there is not in compliant with the state code.
Yeah, I don't see any option for the Board of Health to make these kind of decisions, because if you look at the other part of the state code, it just seems like it's not a function of the board. And then, but there's that issue, the details of our local code versus do we even want to have one? So, yeah.
Is that?
there we go.
I think that the appeal to the courts can be done locally, but that's for another discussion.
It
Yeah. And it does-
it can be, or they can
outside
go
the
to
scope of
Charleston.
the
It gets complicated under the rules.
Right.
So maybe in replace, if they could be reconciled, like in place of aid,
I would-
that's the language about the state administrative law judge determination or something like that.
And I'm happy with wanting to have like the second opinion from somebody at the state before you have a hearing. That's not something that's mentioned in the state
Oh.
rule. So that's something, and I don't think that we would be out of compliance necessarily, because we're just trying to get all the information before a decision is made while the health officer is, so. So I mean, but I would consult maybe on something like that as being part of our local health policy, but I just don't think that they should have the option to appeal directly to the Board of Health, because that's out of compliance with the state code.
All right, so some of them you're obviously gonna work with the
Yes,
gentleman,
that's fine.
and reconcile with the state code, but what you're thinking is the 8 becomes the state pathway, and then adding in a step for an internal second review before the initial hearing locally. Is that kind of what I'm
Right,
understanding?
and I think we just need to include
Okay.
that we're also, following 64 CSR 1, and basically just maybe adding in a couple things for clarity for the health officer, so.
Mhm.
But, and if it's okay for us to have them appeal to the board at some point, but I don't think that is something that would be in compliance.
Well, they can come in and give public comment, we just don't have jurisdiction over making a decision,
Right.
so.
It
Per
mentions
state
in
code.
the agency rule, it mentions how hearings conducted. Any party should have the right to be represented by an attorney qualified to practice in the state of West Virginia. The Bureau may be represented by the Office of the Attorney General,
Mhm.
so they have a stake in this.
Yeah, so I'd actually maybe even just go to the AG's office for the opinion. And they're usually pretty good about turning that guidance around.
Yeah.
Okay, anything else on this issue? Any questions further? Anything else you'd like staff to examine as they get back to the drawing board? Okay.
Thank you.
All right, preliminary budgets.
So I just want everybody on the board to understand that, I want to make sure that we have eyes on the budget for fiscal year 25 and that these numbers right now are still very, very tentative. I'm expecting the total revenue roughly in line with what we're expecting this year, based upon what I'm hearing coming out of Charleston. I'm not sure how much the public health budget's going to increase, so I'm not sure exactly how much we're going to receive in state aid. I've kept that number flat and assumed no increase in that. I've also assumed no county aid. So what I've done is I've kept an idea of where we were at the end of February in clinical revenue and extrapolated an extra $10,000 over that, assuming that we do generate another $10,000 in clinical revenue for the rest of this fiscal year, which I think we easily will. I've kept the permit fees in revenue the same. I've kept the environmental fee services the same. Grants will be in line also. And I've kept those the same. And I've kept others going, donations, interest, rebates, those type of small little $10,000 and $15,000 grants in line also. So I'm expecting a revenue of about a 1.4 million, which is similar to what we budgeted for 2024. The difference now is in expenses. Personnel expenses are going to be significantly more. Being fully staffed going into fiscal year 2025 is very different than not being fully staffed going into fiscal year 2024. We will have an increase of, I believe, anywhere from 3 to 4 full-time permanent employees. That will end up costing us about $200,000 more in personnel costs. So being fully staffed is not inexpensive. It is an expensive thing to be fully staffed, but it also provides a lot higher service to the community. So that's really what the goal is here. Operating expenditures, I kept pretty much flat. I do think we're probably going to end up with operating expenses over budget for fiscal year 24. So I wanted to raise that to put it more in line in 2025 to have similar type of operating expenses. Vaccines have not gone down in cost. Medical equipment has not gone down in cost. In fact, I would say that they've gone up over the last 3 years, probably anywhere from 20 to 25%. And so adding that in, I probably will come back with a larger operating expenditure estimate for the 2025 fiscal year. So as of right now, we're running probably $180,000 to $200,000 budget deficit proposed without any increases in state aid, county aid, or any type of grants that are unforeseen. So we'll see what happens once the state legislative session goes through and we see what public health monies come towards to the local health departments and what state aid numbers will look like. But I'm not expecting it to be significantly more than the 471,000 we received this year.
And hopefully some money from the county commission.
Well, we can discuss that when I do my administrative report. So as of right
How
now,
about the opioid money? Are we subject to receive or eligible to receive any of that?
I'll like to discuss that in the administrative report also. This is just so I can get everybody's eyes on it, the Board of Health eyes on it, so that you understand that this is being developed. It's an iterative process. Once I get some,
Oh, it's copies, it's-
yeah, why don't you pass it out?
Very proud. It
Okay, they all have
was
one.
with you.
All right. So
Later
it's
with you.
it's an iterative
Oh,
process. Thanks.
Okay,
And
sorry.
doing that and waiting for some of the, the final numbers to come in, I think will make that number look a little bit friendlier to us. But in the meantime, this is what I see as of this moment at the end of February.
What we've done in the past with new programs that are proposed but not yet online, unless we have in writing that the the monies are approved, so, so grants, correct. We don't put them in the budget until we know they're gonna exist, so neither the cost nor the revenue. And that's where some of these increased expenses over revenue are, over the budget, is that the QRT grant that, I believe those are, not all those people were included in the budget of, and so that would be the same with the opioid money, if these would be expanding, what we're doing.
And that's just, this is just to get your guys, get your eyes on it so that you understand what I'm seeing from my perspective right now. And I'm definitely subject to change.
I remember last year, the first preliminary, the early preliminary you did was right around this same, and every iteration, it got much closer to where it needed to be.
Correct.
Rhyming with zero.
Yes. rhyming with-
That's always the goal.
Yeah, even -180 rings a bell is what the first cut of this was last year.
Yeah, I think actually it was -212 was the very first one, but that was again, not without knowing state aid and all those things. I want to get that out so that just everybody has an idea and it's not a huge surprise as I show the iterations over the next meeting or so, and then in May, we can have a very firm number that we can all agree upon and move forward from there, so. Very tentative, just discussion only.
Thank you.
Okay, agency reports. Environmental.
So, for sanitarian, the newest sanitarian, is on his third week of training at the state, so. I know, yeah, well, Mason's on his third week of training at the state, so hopefully he'll be ready soon, because I've had one sanitarian out for the past 2 weeks. She was on vacation and then got very sick, and so hopefully she'll be back next week and healthy. So numbers, a little less than last month on food and general sanitation. Our well and septic continues to be extremely busy. So one of the reasons, like when I have one of my sanitarians that right now I only have 2 sanitarians that can do the well and septic, because one is just on food. She's under the NEHA grant. So when one of them is out for 2 weeks, that means the other has to cover septic that time, and food inspections get put on the back burner again. So that's what happens with that, but we've continued to be extremely busy. We never really experienced a freeze in the soil this year, so septic work has continued, and
Means lots of bugs this summer.
yeah, so
Talk about staffing real quick.
so staffing, basically, I'll be very happy when our 4 sanitarian is trained. I'm working on doing, training for the grants that just got the funding back from, so, and the one reimbursement that we got for the grant, the largest one, that's the last one that, for our 3-year grant that we have, they pay that ahead of time, which is nice, so. But staffing, we did just hire somebody for the front desk. She starts on the 19th of March, so we're excited about her as an addition. I think she'll be great. So she has a lot of experience. She's working with DHHR right now. She's a state employee, so a lot of experience doing the type of work that she'll be doing up there. So I mean, not septic applications, but she'll learn, and I think she'll be a great addition, but until she's trained, which it's going to take a while, because it's not, what she has to do is not the easiest thing to learn. So processing septic applications and trying to figure out what they need on them before they can even be submitted to the sanitarian is something that there's a lot of questions about, and how to find the files and everything else, so. Because we still have paper files predominantly, so. And we've had some issues with the past staff that was in here. We keep finding more discrepancies where things were not being scanned properly into the system that we were paying for this. So basically, she's created a lot more work where we almost have to start over with the scanning project, so. So yeah. It's just been very busy for the one staff member that's covering 2 positions right now, so.
Elliot, did you have a question?
No,
Oh, you're good?
I thought you wanted me to unmute. That's all.
Yeah, oh, yeah, I did, because I had muted you, sorry, Elliot, that's all.
No worries.
Just wanted to make sure you had an open chance to speak openly if you'd like to, that's all.
Thank you.
We've all been keeping very busy, so, and then we're gonna be happy when we're fully staffed, so.
Any questions for Gillian? Right, threat preparedness, I guess you'll cover that.
Currently, I'm the threat preparedness coordinator for the health department. I did attend a meeting in Kaiser, lovely downtown Kaiser, and got to work with coordinate with the other 8 counties that are a part of the regional threat preparedness team. So I've done that. We've worked through that. We're beginning to assess the regional threat preparedness plan and things like that. So that will continue. The new threat preparedness coordinator will begin on March 11th. So on Monday. Good young man, master's degree in emergency services and threat preparedness, very much into this. Very much experience, has a year of experience as an intern while he was completing his master's degree in Pennsylvania. So he is into this, he knows it, and he's going to be a great hire. He's and personality wise, he fits in perfect with our organization. So I love a good, diligent young professional, and that's what we're getting. So much else on that one.
Clinical?
Sounds like 2 good new hires.
Yep. We are not having any difficulty hiring anymore.
Good.
That's great to hear.
For the clinical report, our numbers have been pretty stable. For family planning, 28 this month, breast cancer and cervical cancer screening, sexual transmitted disease and infections and vaccinations, and TB test. We're holding steady. It's where we expect it to be this time of year. No particular anything to report other than that.
Thank you. Any questions? Okay.
Thank you.
Dr. Reedy?
So this is extension of clinical report, COVID numbers have gone down by the data that we received from the state and the feds. Not really a lot gets reported to us. The influenza is still perking along. It's not an extraordinary season, but it's kind of dragging on a little longer. But hopefully that will go down. The guidelines on what to do if you have a respiratory virus have become much more generic in the last 2 weeks. It's what people have largely been doing anyway. The guidelines saying that
Shocker.
if you're better, you can go back. What a lot of people are not doing is when they go back, they're not necessarily keeping distance or wearing masks, but when you feel better, you still could be infectious, and that's for any of the 3 major or even less serious respiratory viruses. So still limiting your exposure. It has not changed for those who work in healthcare setting. The guidelines did not change for them. So for our nursing homes, when they have cases, they're still considered outbreak status. We have not seen measles cases here. There's lots of talk about it. This is going to likely be just part of the new reality as the vaccination rates have decreased. There then become enough people who have no immunity that if they are exposed, they could get measles. Certainly seeing that throughout the world. It's not just here. So the outbreaks you're hearing about are not outbreaks like in Central Africa, where it's tens of thousands or more people getting it. It's clusters But it still can be real. So we still encourage vaccination. There are a lot of illnesses that we don't see now because the effectiveness of vaccines, but the opioid monies are, going to be available to spend, and the different municipalities or counties and state organizations that have the purse strings will be looking at projects that next month, I think April 15th, in the evening, the county commission's having a town hall meeting on the opioid problem. And the health department will present to that along with other community partners, and one of our big roles is going to be working with partners to establish a plan. And that's something we have to figure out. So anyone that wants to attend certainly is welcome, and anybody that has ideas, what we can do. There's lots of options of how you interrupt this process.
Anything else? Any questions? All right. Yeah.
Don't want to waste you guys' time, so we did hire the 2 new staff members that were discussed earlier. One is an office assistant, the other is the prep coordinator. Also, we are adding a 3rd LPN position that will be filled by a current staff member who's in an office assistant position. So we will be looking to fill the office assistant positions. I'll probably post that next week. And then we can have a better functioning clinic. It's never nice when you have a shortage of nurses and you have to cancel appointments. And that's something I would prefer not to do. I was in private practice for a very long time. That's something completely 100% avoid at all costs, is canceling appointments, and having a 3rd LPN will help mitigate a lot of that. So I want to thank everybody on board who spoke to the county commission. I want to thank our commissioner also for entertaining us. Gillian and I did go in front of the county commission and discuss and request county funding, operational funding. So we'll see what happens with that. And any of you who helped assist with that, I appreciate it. One of the things we discussed while we were there was our QRT program. And just quickly, and I am certainly not as fluent in it as our 2 clinicians. And I want to make sure that Commissioner Jackson's request, which I thought was a very reasonable request, was that we, as the health department, we should be coordinating with all the other agencies in the county that are involved in this, to make sure we reduce redundancies and increase efficiencies. So that's something we will be doing next week. We'll be meeting with a community partner, and also Lindsay and I spoke with a representative from Harpers Ferry and a representative from Bolivar last week about their QRT money and how they might want to spend it, if they would be interested in spending it with us or our QRT program or something else, or something that we could do together and, coordinate with them. So that's currently underway. We're trying to figure that out. And speaking of the QRT, I have not yet billed the 2nd quarter. 2nd quarter finished at the end of February. I'll bill the 2nd quarter. It was roughly about $58,000. The 1st quarter was about the same. We were able to bill that, and that is in process, and hopefully we'll be reimbursed for that within the next few weeks. One of the big things that I'm quite proud of our team is how much revenue the clinical side is producing. That's a testament to our nurses, to Dr. Reedy, and also to Lindsay, that we have put in place processes to make sure insurances are billed, to make sure that the expenses that we are incurring are offset by revenue, and we've been able to do that. I don't know if we'll eclipse the $400,000 that we ran clinical revenue last year, but I think we probably will, and that would be an all-time high for the Jefferson County Health Department, so. It's never been this high, it's never been $400,000, and I think we'll probably eclipse that this year again, so. Kudos to the team, well done.
Good job.
Yeah, good job.
That's what's been sustaining us last few months. So. I have
And
nothing
the
else to say.
reason that they got a new exam.
Yeah, that helps too. Makes it a little more, nice to be in those rooms.
Yeah,
For sure, to work in them also, and that's all part of making sure your staff has the tools and the support that they need to do the job well, to do a job well, and to feel like that they're being supported and they're not being, asked to be working with second rate and third rate tools.
yeah, I remember taking a tour when I first started on the board and remember those rooms being very good. I can't wait to see them.
So you talked about new office space in your notes here.
We did. Please ask me all about that. Yes, so currently the former Red Cross office is being used by another tenant in the building for storage. It's not being used as an office, unfortunately. It's actually over here, not this side, it's over here. It's a large space, including 4 offices, a private bathroom, which would be fantastic for our QRT, and or if we go beyond that, if we do any type of clinical or do any type of speak. So what would you be required to be a fully functioning nurse practitioner?
For our OB MAT, medication addiction treatment program that we are trying to implement, it does require a private bathroom to monitor drug screens. So we currently do not have a setup according to what's required for that. That would require renovations in the current bathrooms to do that. So that's why I said this bathroom would be ideal. And then we do definitely need private offices to have one-on-one seeing the patients. Currently, my office I'm sharing with the peer recovery coaches. I don't really have a space to sit one-on-one with patients and see them. So that is there. We have 3 nurses coming in. We already have 2 nurses in a 2-nurse room. And the 3rd nurse, we actually are trying to figure out where we're gonna have her sitting. So there's a lot of spatial issues, and the peer recovery coaches right now, what I'm planning to do until we have an answer is they're gonna have to sit in the conference room. Until we have a space that is sufficient.
So that was the request in there, and that's the reason why. It's as we expand.
Who's currently using that space?
The West Virginia University Extension Office.
And I certainly do not want to run afoul of them. They've always been good neighbors with us. Polite and friendly and professional, so I don't want to run afoul of them, but I would like to use this space in the manner in which they were designed. They're not storage spaces. These are offices with phone lines and internet lines and private offices where I would like to have the clinicians to be able to have some private space to deal with patients on a one-on-one basis in privacy. And that includes Dr. Reedy, but also certainly Lindsay Gregory, our nurse
I
director.
think
So
I've heard you mention that being used for storage before. Who's using them?
The extension office.
The extension office have storage space in offices that you could use. Okay,
yes, and like I said,
no, I understand.
I'm certainly not doing that. I'm just trying to address our growing pains. That's all. Growing pains, right? There's a growing pain.
Pains.
So one of the
Hunger
commissioners,
pangs.
one of the commissioners did mention when we were there that they were possibly getting another agent as well, but I don't, right now, it's just being used for storage, and they're talking about 1 additional person.
Okay,
So,
okay.
Being able to offer our clinical services nearer to the population center would be a nice thing that becomes lots more money and planning and all that.
Absolutely.
So I don't think, we're there, but it would be, nice to be able to do that.
Well, is
Ideally-
Jefferson County Ministries, they're moving out to a new space, right?
They will,
So
and
it's-
we're,
They
will.
will, yeah.
So what about that old space?
so So these are all options, and we're gonna be discussing collaboration with them. You know, whereas we collaborate but still be, you know, our own separate missions. But it's, you know, this is not, even if you had bus service come here twice a day, that's not very convenient for getting dropped off and then waiting till tomorrow to get picked up. You know? So it's, you know, for those with transportation needs, which is very real for a lot of the people who want services, this is not convenient.
That ideally, at least the clinical side and the QRT or the OB-MAT program would be best suited in a population center, either in Ranson or in Charlestown and somewhere, which would allow short distances for the majority of the population in the county to be able to access those services. I would hate to be the administrator with the environmental health and the clinical health separated by several miles, but that is not unheard of, and it's not unusual in the surrounding counties in Virginia and Maryland. That's fairly routine, actually. So, do want to mention one last thing. We have not had any problem recruiting or retaining staff. So that's good news. We have staff now, like Gillian, who've been here for more than 5 years. Our nurse director now has approached 2 years, I believe.
Has it been 2 years already?
Almost.
And so, and I've been in my position, I've been in my position for 2.5 years. We have other members of staff who've been on, and prior to Gillian's arrival, that was not usual. And I think Ann remembers how staff turnover
And
was.
Dr. Reedy's been here about that.
He's also been here about 5 years,
Almost 5 years.
It's almost 6 years.
almost 6 now for Gillian. So
So the one area we have had trouble recruiting and not success is a social worker.
Yes.
So as you get into the medical field, being able to compete for staff is difficult. We were able to get Lindsay because she's interested in the population we serve, and hope we can keep her for years and years, but but that is a problem going forward, is that the prices of healthcare staff are just climbing and climbing and climbing.
Social workers and therapists are in dire need in our area. Can't find anybody, not just to hire, but if you talk to people, they can't. A lot of population is not getting the services they need. It's so underserved. Therapy and social workers, case managers.
we'll find one.
So our next meeting, April 12th, right?
It
Yes.
is.
All right.
I don't think there's a weird holiday that day, so. Sorry. I don't think so, though.
All right, is there a motion to adjourn?
I move we adjourn.
Second.
All right, all those in favor for adjournment, please say aye. Aye.
Gotta raise your hands and I'll leave.
I know, yeah, gotta raise.
Yeah,
hand.
we got it.
All right. All right, thanks, everybody.
I.
Thanks, Ann.
Thank you, Ann.
Thanks, everybody.
Thank you. So we're we off the recording?
I'm gonna hit the recording right now.